عرض سلام و احترام برای تمام شما عزیزان. خوش آمدید به پروگرام چهارم هفته‌وار ما. من پرویز کوهستانی هستم، متخصص جهاز هاضمه از آلند. به نمایندگی دکتران افغان شما را خوش آمدید میگم. ما خیلی خرسند هستیم که در پروگرام امروزی خود بازم دو از بهترین متخصصین خود با خود داریم و امروز محترمه متخصص لیمه جان صدیقی نادری و محترم متخصص صاحب سمی نادری را با خود داریم. البته از تخلص برای شما شاید ویدا شده باشه که هر دو خانم و شوهر هم هستند و از بهترین متخصصای ما در هلند هم هستن و معلومات کامل در بخش کووید دارن. امروز شما مضمون دیدین که پیرامون 3 بخش کووید است و من زیاد وقت شما را نمیگیرم و در آخر پروگرام وقت کافی به سوال جواب هم وجود داره. معذرت میخوایم از اینکه کمک سکتگی در پروگرام وارد شد، به خاطر که ما امروز قراره که شما مشاهده کنید اولین دفعه بود که از وبکس به زوم پروگرام ما انتقال کرد. من فقط تقاضا میکنم از همکار محترم ما که لکچری را که آماده کردن شروع بکنن. بفرمایید دکتر صاحب محترم.
سلام برسه بر تمام همکارا و دوستان عزیز در افغانستان و در آلند سایر نقاط دنیا. تشکر دکتر پرویز جان از اینترودکشن، از معرفیتون و تشکر از اینیشیتیو گرفتین. امیدوار هستم که بتانیم از این طریق دانش شیر کنیم و امرای دوستای خود در افغانستان و از اونا یاد بگیریم در اینجا. من نمیفهم که زبان انگلیسی است، پشتو یا دری. به نظر من اگر دری یا انگلیسی باشه، نظر شما چی است؟
درست است. هر زبانی که شما خود حاکم برش احساس میکنین و میتونین که با همون زبان تشریحاتتان داشته باشین. اگر دری شوه نور علا نور، در غیر از او انگلیسی هم درست است.
درست است. خیلی. I would like to today present the new insight into treatment of COVID-19. You may already know a lots of information, and you may already gain lots of knowledge, but I would try to focus on the current consensus and the guidelines. Nothing for disclosure in this presentation is meant for our Afghan colleagues, and during the preparation of this presentation, we tried our utmost to gain and to provide the accurate information and updated evidence-based information. And of course, we do all agree that this guidance doesn't replace the professional judgment during the treatment of COVID-19. And also seeing the dynamic change of the knowledge in COVID, so that every week there will be new data available that we might change our approach. So I'm going to start about the start of Outbreak, and as we may know that at the end of December last year, there were 3 cases of pneumonia without a causative agent reported by Chinese physicians to the Chinese CDC. And later, and they thought that there was a link between a seafood market and this pneumonia. That's why they have closed in China the seafood market. And on 3rd of January, they were informed WHO. They have informed WHO about these pneumonia cases, and they were able in China to identify the SARS-CoV-2 microorganism, which was similar to SARS 2003 with some differences. At 11th of January, they have shared the 10th of January, the sequences of the PCR with WHO. And thereafter, they closed the Wuhan city the 23rd of January, and they locked down China, and it was a huge operation. Before I giving you the information regarding the new insight into the insight to the new treatment, it's I think it is a good idea to take this slide into consideration and remember a couple of facts that after the incubation phase, the disease COVID-19 will present itself in 3 different stages. So the early infection phase or stage will be the viral response, whereby there will not be that much of complaints, mainly mild symptoms, fever, cough, diarrhea, headache, some lymphopenia at the lab, and also increased D-dimer and LDH. The second phase, which is already 2 phase, 2A and 2B, which is a combination of the viral response phase and the start of host inflammatory response phase. Develop more complaints such as shortness of breath, hypoxemia, and also if we test for example, chest X-ray or CT scan, we will see also abnormalities in that phase. Followed, if there's no treatment and the disease progress, whereby the viral response will be almost down, but the host inflammatory response will be high. So at this stage, the patient might develop SARS or ARDS, cardiac failure, multi-organ failure. So the same different stages, WHO made also a clinical classification of COVID-19. The WHO made 5 different whereby the first stage is asymptomatic or pre-symptomatic infection, then mild illness, followed by moderate illness, and if there's no treatment or if the disease progresses, then it will lead to severe illness, whereby the individuals develops more respiratory problems, higher respiratory rate, low oxygen saturation in the room air, and also in the lung by X-ray or mainly by CT scan, we will see more abnormalities. If the disease progresses, we will see critical illnesses, whereby the individual might develop respiratory failure, septic shock, multi-organ failure, which is a very critical stage and very dangerous stage. So if we remember the first 3 different stages in the previous slide, which was this one, comparing with the classification of WHO, we have made also our own classification, whereby this classification, as you see, we made the disease in 5 different levels. Level 5 is the mild or pre-symptomatic or asymptomatic phase. If you see at the left side, we have made the triage level, the condition of the patient, the how dangerous is how obvious is the critical or the clinical stage of the patient, where the patient needs to be treated, mainly in the resources limited facilities is important, and then where to treat the patient. So we have made those 5 levels. The level 5 is a stable patient. The patient will be discharged back to home after evaluation. Level 4 is a patient who might need some treatment, some oral fluid in case of dehydration due to diarrhea, or some low fever lowering medication, and ruling out the other infections. Those patients might be admitted in what we call mobile medical pavilion, which is close to our main building, main hospital, and then we treat them, and thereafter they will be discharged to home. The level 3 of care is the patient who need the oxygen, need bronchodilators, IV medication, IV antibiotics, and some additional investigation. So in a limited facility, what you could do is to create such a mobile unit beside your hospital, so your regular care in the hospital could be continued. And then you could admit those patients at that pavilion and treat them. And the goal is to stabilize them so they would be able to be discharged. The level 2 and level 1, those are the severe disease and the critical stage, whereby the admission at the intensive care is needed, and more investigated, more aggressive. So those 5 levels of the care is important to understand, because you make the choice of treatment based on the level of the condition. Now, how can we understand which patient is in a poor condition? So we have created a early warning sign, and I believe that every hospital has its own early warning sign. And what we have done is we have chosen the international guidelines for choosing the early warning sign. And we made a scoring system. Based on the scoring system, we know whether a patient and which critical condition is the patient. To give you an example, you see at the left column the score. Now, then you will see 3, 2, 1, 0, 1, 2, 3. I will explain what does it mean. Rate is lower than 9 per minute, then you see that the patient scores 2. If the respiratory rate is between 9 up to 14, then it is a 0. And if the respiratory rate is getting higher, you will see that the scores gets also higher. For example, if the respiratory rate is more than 30 or more than 30, the early warning score will be 3. So the same applies for the heart rate, for the blood pressure, temperature, and the oxygen saturation. And finally, the level of consciousness. For example, A is for alert. Now, if a patient is alert oriented and time, place, person, it is a 0 score because it's a normal condition. But if a patient is reacting only to voice, that will be 1. If the patient doesn't react to voice but reacts to pain, that will be 2. And if a patient is unresponsive, it is 3. On top of that, if it's a new onset of confusion, which is 1. So you make a calculation based on the early warning score, and then the calculation will tell you if the score is more than 4 or more than 4, those patients are unstable patients. So those patients needs more attention, and we will not admit such patient at the pavilion, but we prefer to admit those patients at our medium care or at our intensive care. So depending on the setting, you might choose where to admit the patient. I can imagine that if in a far village in Afghanistan, that there might not be possibility to have the intensive care or medium care. So at that case, what you could do, you do what you are able to do. And by screening more until you transfer the patient to the high care facility. Now we are going to discuss what are we going to do with the treatment with the patients with COVID-19 and what kind of treatment are advised or recommended based on the current data. The main supportive treatment. By saying this, providing oxygen to our patients, providing intravenous fluid if it's needed, because we do not want a wet lung. We prefer to have a dry lung. So if a patient doesn't need intravenous fluid, you should avoid giving intravenous fluid because of the risk of wet lung. Further, the correction of the electrolyte and acid-base abnormality. Dr. Siddiqui Nadri will touch this part later, and also managing of anxiety, delirium, and agitation, because the patients are usually in isolation, and there are new data available that the neurological involvement of the COVID-19 is more common than we think. So managing anxiety, delirium, and agitation is very important. And if a patient has sepsis, we have to treat the patient according to Surviving Sepsis Campaign, the guidelines of the critical ill adults, which we will come back to that later. Here in this dia, it is not that much clear, but I try to go with you through the chart, through the flow chart. We start with regular flow nasal oxygen through the nasal cannula. It depends once again on the clinical condition of the patient. If a patient is in need of oxygen supplement and the patient is reacting properly, so we keep doing this. But if we notice that the patient is deteriorating while the patient is on nasal cannula up to 6 liters per minute of oxygen, then of course we have to go either to high flow nasal cannula or CPAP. Once again, depending on the setting where the patient is at that point. If it's a place where with limited facility, of course, the possibility of CPAP or BPAP is not there. So we have to focus on nasal cannula or high flow nasal cannula. If you don't have both of them, then non-rebreathable masker is the only option until you transfer the patient to a center with more facility. If the patient is improving with high flow nasal cannula or CPAP, then you continue doing this. If the patient is deteriorating, then of course we have to go to the next level, and finally with adjusting the CPAP, and finally invasive mechanical ventilation. I'm not going to touch that part because my colleagues that, and they will touch in another setting, and the mechanical ventilation part. And if the patient is improving, recovering, then you start down-regulating from invasive mechanical ventilation to CPAP, high flow nasal cannula, and finally to low flow nasal cannula, until you stop with additional oxygen and you let the patient get improvement in the regular room air. Now, the other aspect is the venous thromboembolism part, the prophylaxis for that, which is the new data shows more and more that it is a micro thromboembolism. It's very important. So to even in a preventive setting, consider to give the patient low molecular weight heparin, or if there is no possibility for low molecular weight heparin or DOAC in some setting, consider mechanical thromboprophylaxis. There are new studies from Professor Levy and also from the American Society of Hematology in this regard. Dr. Irfan Noor is our expert in hematology, and that part will be addressed by him. So I'm not going to further in detail of this part. That's the same about the anticoagulation, and very in this flowchart, whether of the D-dimer. Of course, you could measure that if in the setting whereby the D-dimer is not possible to test, then how to deal with that part, which will be also discussed by Dr. Noor. Now, my main focus is now about the treatment of COVID-19 itself. So the treatment against SARS-CoV-2, against the virus itself. What are the options, how we are dealing with, and what to do, and what are the consensus internationally? We all know that the treatment of COVID-19 is a big challenge. There's lots of therapeutic dilemmas. Why it is so difficult to find a proper treatment for COVID-19 which covers and which suppress the virus and the complications and the consequences of the disease. Based on the previous studies, we have various antiviral drugs. Now, the primary targets of those drugs is the DNA targets rather than the RNA. And the RNA, mainly we are focusing on HIV treatment. So the treatment that we have so far, the data that we have is from HIV studies, from SARS in 2003, and from MERS in 2008, if I'm not mistaken. So that is the data that we have, and also from other viral diseases, such as hepatitis B infections, hepatitis C infection, and also from influenza. The other group of treatment is immunomodulatory drugs, so anti-inflammatory drugs. We have lots of experience with these drugs, but in a different setting, in a setting whereby the chronic inflammatory conditions such as rheumatoid arthritis, SLA, but not in an acute inflammatory setting. So there are some studies that it might be effective to treat COVID-19, especially in a second stage and the third stage of the disease, whereby the hyperinflammatory state is very active. And then the anti-malarial drug such as chloroquine and hydroxychloroquine. And those are, it seems that they have some beneficial effects. And in vitro studies from the previous studies during SARS in 2003 and also during the MERS, that both medication might have some beneficial effects. But there is no clear studies so far until the start of this disease on COVID-19. It has also side effects. There's also another group of the drugs which might be effective, which is corticosteroid. Although there are lots of controversial information on this. Now, the consensus on corticosteroid will be shown soon. And in a few slides, I will show you what are the consensus to treat COVID-19 with corticosteroid. Of course, there are some other studies with some other treatment plans, some of them controversial, and the majority of them are not available in Afghanistan and some other area because those treatments are in trials and in research setting. And the availability of those drugs are also another question. One of them is remdesivir, made by Gilead, but that is a specific program whereby the but in limited facilities it is not possible because the requirements is also very strict. The other drugs, other treatments which might be possible, is the plasma exchange of the antibodies of the healthy of individual who had the COVID-19, and they might have antibodies against the disease. So that in some settings they are using plasma of donors to the patient who are very sick due to COVID-19, and they are trying to neutralize the virus by giving antibody of a cured person. So those treatments requires also high facility, and also it is not a standard treatment, but is only in research and trial settings. What is the consensus so far? What I am going to advise you based on the studies is the following. So it's a little bit a busy slide, but I am going to try to explain. At the left side, as you see, is the different stage of the disease. So the mild stage, the moderate to severe stage, and the critical stage. Which treatment is recommended and which stage. So the mild stage of suspect or positive or confirmed COVID patient, no requirement for any treatment whatsoever based on the current guidelines. The patients moderate to severe disease, suspect or confirmed, who need admission as well as oxygen treatment. The current consensus states that either choose hydroxychloroquine, plaquenil, or chloroquine. Now, the dosage is the hydroxychloroquine is the loaded dosage on day 1 is twice a day, 400 milligrams, followed by twice a day, 200 milligrams from day 2 up to day 5. So in total duration of 5 days. Or you may choose chloroquine instead of hydroxychloroquine. Loaded dose is 600 milligrams, followed by twice a day, 300 milligrams, total duration of 5 days. Of course, you should take the kidney function into the consideration when you are choosing these medications. So the adjustment of these medications to the kidney function is needed. That will be addressed by my colleague, Dr. Siddiqui Nadri. Also, based on the current data, we advise in combination of antimalarial drug to add antiretroviral drug. Now, the safest drug is so far is lopinavir, ritonavir, just Kaletra, twice a day, 2 tablets. Each tablet has 200 milligram lopinavir and 50 milligram ritonavir. So it will be twice a day, 400 milligram, 100 milligrams for 14 days. Or you, because the Kaletra has more side effects, diarrhea, for example, you might choose for darunavir, which is Persista, once a day, 800 milligram, plus ritonavir, once a day, 100 milligram, also for 14 days. The last one is more expensive. Also, it depends on the setting where these medications are available. On top of those combination of antimalarial drugs and antiretroviral treatment, we advise also ceftriaxone once a day, 2 grams, which is rosifin. Of course, every hospital has its own policy regarding antibiotic, but which we have chosen for ceftriaxone, rosifin, to cover the eventually the secondary bacterial infection, superinfection, and it covers gram-negative rods as well as gram-positive COX. So it's a broad spectrum antibiotic, and it even covers Staphylococcus aureus in certain grade. Also, the consideration is to add doxycycline or azithromycin. Now, the use of doxycycline or azithromycin on top of the medication such as antimalarial and antiretroviral treatment is because some in vitro studies showed the beneficial effect of doxycycline or azithromycin against the virus itself by leasing or damaging one of the part of the walls of the virus. That's why that the current data shows that the patient might have some beneficial effect of the combination of doxycycline with antiretroviral treatment with antimalarial drugs. Azithromycin has more side effects. For example, prolongation of QTc time. Also, chloroquine, hydroxychloroquine, also cause prolongation of QTc time. And if you combine both with azithromycin, there will be even more prolongation of the QTc time. At the top of this medication, we consider Tamiflu, oseltamivir, or zanamivir. Zanamivir is an IV, and oseltamivir or Tamiflu is oral, until the influenza A and B PCR is negative. We gave this for 5 days. Meanwhile, we gave, of course, fragmine prophylaxis, or DOAC instead, or paracetamol, and also paracetamol to suppress the fever. In a critical patient who needs admission to the intensive care, who needs ventilation support, either non-invasive or invasive, the treatment regime is almost the same as previously, but we are more aggressive in treating the patient. One of the differences that you may see is the same dosage of hydroxychloroquine as that you are giving in malaria. So my colleague in Afghanistan, probably they have much more experience in treating malaria than we do have here in Europe. For example, one of the strategy is to give loaded dosage of 800 milligram of hydroxychloroquine at time 0, and then every 6 hours 400 milligrams, and then the following day twice a day 400 milligrams for 5 days. Or you choose 600 milligram loaded dosage, then twice a day 300 milligrams also for a total duration of 5 days. Or if you choose chloroquine, 600 milligram loaded dosage followed by twice a day 300 milligram for 5 days, in combination of antiretroviral treatment, Caletra, or darunavir, ritonavir. In this setting, we considered to add the steroid. And the steroid, additional benefit of steroid might be in a patient with ARDS. For the other COVID-19 patient, it is controversial, the benefit of steroid. But for ARDS, it might be some beneficial. So this is what I recommend, and I have recommended also at our hospital based on the current data. Now, how did I come to this conclusion? And how I choose the different literature as well as the Infectious Disease Society of United States and the European Society of Infectious Diseases. And based on the following guidelines, we came to this conclusion. And we used for the evaluation of the guidelines the GREAT methodology. It is also a busy slide. I'm going through with step by step. If you see that the step 1 is rating the quality of the evidence. Now, the first part of the quality evaluation is the level of confidence. Now, the study design is very important. If it's a randomized trial, it has a high confidence. If it's double-blind, even higher. And if it's observational studies, low confidence. Once you evaluate the level of confidence, you go to whether that confidence, the level of confidence increases or decreases. And how you do that, you see if there is a risk of bias, inconsistency, indirectness, imprecision, and publication bias. It is it has negative influence to the level of confidence. So the level of confidence will decrease if you see one of those 5 aspects. In contrast, the level of confidence increases if the effect of the study is larger, with a large effect, if it's dose response, and there is no bias in it. Then in that case, we could say that the level 1, we establish the initial level of confidence. We adjust the level of confidence, either lowering or highering. And then finally, we gave a rating to the level of confidence, and that final rating is based on 1 and 2. How higher is the final level, how better and how reliable will be the results of the study, which will be shown in the next slides by 4+, 3+, 2+, and 1+, which is very low. If you're done with the rating of the quality of the evidence, then you go to determine for the determinants of the strength of the recommendation. And that one you could have it in one of the 4 circles that you see, is that the quality, certainty of the evidence, balance between the benefits, arms, and the burdens, patient's values and preference versus resources and the cost. Now, if I may look at sitting in Afghanistan, I would say that the quality and the resources and cost, those two are important, plus the balance between benefits, harms, and burdens. Knowing that in Afghanistan is mainly paternalism is a way of practicing the medicine, than the respect of autonomy, such as in Europe and the United States, whereby the patient's value and preference plays a major role in Western society, while in Afghanistan, that part is unfortunately not the case. So I believe that at current setting in Afghanistan, the resources and cost are important, balance between benefit and harms and burdens, plus the quality. So the focus is, unfortunately, at this point in those three circles, and hopefully in the future also the patient's values and preference. And finally, the implication of the strength of the recommendation. So we start with rating the quality, then we look at the strength of the recommendation, and then finally we came to a conclusion whether it's a strong recommendation or a weak recommendation. So based on this great methodology, we looked at the literature and the first outcome was based on the study Chen J et al., Chen Z et al., and Wang. Now, this is also a busy slide, and I will go with you through the slide. If you see in those three studies, they compare hydroxychloroquine, the patients with COVID-19, they compared the patients who received hydroxychloroquine compared with the patient, and all patients were admitted. They compared the mortality rate. The follow up was 14 days. They checked the clinical progression, clinical improvement based on the radiological finding, failure of virological clearance, followed up by PCR, and the adverse event. And if you see the mortality rate, you will see that the certainty of the study was very low. So it is a weak recommendation. And what they state is that there was not that much difference between a group who received hydroxychloroquine versus the group who improvement has been seen by the patient who did receive the hydroxychloroquine. And you could see it in the second study, and actually in the both studies, 1 and 2, and the clinical progression. And you see at the effect, the 90 fewer per 1,000 patients in the progression of the radiological findings, and day 3 and day 6. So what does it mean? It means that the group who received hydroxychloroquine, 93 patients in 1,000 patients showed less progression comparing the group who didn't receive the hydroxychloroquine. You see also in the clinical improvement of the group who received hydroxychloroquine, you see 258 patients more per 1,000 improvement in the clinical, in the radiological finding at day 6. So the first one was the clinical progression, which showed 93 fewer per 1,000, progression, while in 258 more per thousand, the improvement in the radiological finding at day 6. If you look at the failure of the virologic clearance at day 7, you will see that 67 patients, more per 1,000, did show the clearance at day 7 of PCR from the group who received hydroxychloroquine. So that is in favor of hydroxychloroquine. But once again, the recommendation or the strength of the evidence was low. When we're looking to the adverse event, any of them, the serious and non-serious adverse event, we'll see that 70 patients, more per 1,000, had side effects. Once again, the difference between the side effects between the group who received hydroxychloroquine versus non-hydroxychloroquine, they were weak. They were not that much different. So the question is whether is that a part of the side, was that clearly side effects, or was that a course of disease which caused trouble? So based on, and also in the old studies in 1999, there were and they have seen the prolongation of QTc time, mainly in patients with systemic lupus erythematosus. And that was already known. So all 3 studies, Chen J, Chen Z, and Wang C, it shows very low certainty in favor of the disease and not in favor of the disease. So in the adverse events and also in the beneficial effects of the disease. So we cannot say to draw a clear conclusion from this study. Meanwhile, these studies had also some limitation because of the time. I will not go in details of the limitation, but these DIAs will be available, so you could go through those limitations as well. The next study, which is also with the same great methodology, has been studied in a PICO, of course, patient intervention, comparison and outcome, was the hydroxychloroquine plus azithromycin compared to the patient who didn't receive these 2 medications in hospitalized patients who had COVID-19. Those studies were observational studies, and also very weak evidence. Even this study didn't show the how many percentage improvement is not measured and also not stated. So based on this study, also we cannot draw a clear conclusion that if you combined azithromycin with anti-malaria drug, how will be the outcome? The majority of the limitations studies were that there was no adjustment for baseline severity, and at the meanwhile, the confounding was not taken into consideration. The numbers of the patients were very low. So in those, the studies that we have been used is Mulena, Gottred, Corin, and Gottred, and Wang. Wang was again, that was the old study from 1999, and one old study from Ray in 2012 on the side effects. of the azithromycin and side effects of hydroxychloroquine or chloroquine. While the other 3 studies are a Spanish study and the new study in China due to this pandemic. Now, the next slide will provide us information on the use of Kaletra in a confirmed COVID patients. And that is a study done by Cao Wang, and it was a trial of Kaletra in adult hospitalized, has been published in March in a new. If you look at the numbers, you will see also that the study design was randomized, which has a better confidence. And then if you go further by lowering or hiring those level of confidence, finally you come to the conclusion that 82 fewer than 1,000, we have seen a beneficial effect in the mortality rate in 28 days in a group who received Kaletra. So in 28 days, mortality rate was 82 fewer than 1,000, which is in favor of use of Kaletra. Once again, the evidence was very weak. If you look at the failure of the clinical improvement at day 14, then you will see 154 fewer. So once again, weak. This is not, it is also in favor of the use of Kaletra, because 154 fewer than 1,000 and the failure of the clinical improvement at day 40. And the adverse event was mainly a gastrointestinal adverse event, also fewer. Based on this study, we could conclude that we do see some improvement, some beneficial effects of using of Kaletra versus placebo and pneumonia due to COVID-19 in hospitalized adult population. Although those beneficial effects, the evidence are very weak. Now we are going to the next chapter, which is the use of corticosteroid comparing to non-corticosteroid in a hospitalized adult patient. Once again, due to the time, I will go briefly in the outcome. And we see that the level of evidence was very weak, very low and very weak certainty, based on the study of for Sun, Wang, Wu, and Liu. All of them are studied, have been studied in 2020 in COVID-19 patients. There was weak evidence. So it was also observational studies. Based on this, we cannot say whether you should give it or not. Even they didn't say how many percentage was the beneficial effect. It applies also the interleukin-6 inhibitor, such as tocilizumab, Actemra, or Reactemra, which is used mainly for rheumatoid arthritis to suppress the acute hyperinflammation state. The evidence are very weak, and the studies were in 3 different studies with limitation in their studies. Based on this, we cannot draw a clear conclusion what to give. So that is also the use of interleukin-6 inhibitor and the steroid use. Flowchart seeing the time limit. I go further to the plasma phrases or plasma exchange of the convalescent plasma of the adult who had COVID-19, and they might have antibodies, and to use their plasma to the patient with COVID, hospitalized patient with COVID. Once again, there is no clear beneficial effect. So the studies is still ongoing. There are no new studies are coming with new results. So let's wait for this. And also, this is not available in Afghanistan. Now, based on the studies that I have shown you, we have chosen in our hospital to use, to not give any medication in a mild cases, to give some medication to moderate to severe suspect or confirmed case of COVID-19 who needs oxygen treatment, and that I explained at one of the beginning slide, chloroquine or hydroxychloroquine plus Kaletra or darunavir, ritonavir, plus antibiotic to cover the secondary superbacterial infection, or also add doxycycline and on top of hydroxychloroquine or the virus itself. And at the ICU, we are more aggressive, and we consider a steroid on top of the other treatments, only in a certain cases that we might think that there are signs of ARDS. So in summary, we have chosen in our hospital these three different categories with three different strategies based on the current available data, and we are focusing on the data on every 2 weeks, unless there is a big breakthrough data available, then we will adjust every 2 to 4 weeks our guidelines to be at the safe side. I thank you very much for your attention, and if there is any question, please let me know.
تشکر بسیار زیاد دکتر صاحب نادری، واقعا که معلومات خیلی عالی بود. سوالا را میمانیم به آخر پروگرام. باز یک دم سوالا اگر بود باز میتونیم جواب بدیم اگر اجازه شما باشه.
Sure. بله حتما مطمئنم.
Thank you very much. میتونن محترمه متخصص صاحب صدیقی نادری، میتونین شما floor is yours.
Yeah, you're doing there or here? Yeah.
Microphone تک. Okay. سلام به همه. میشنوید صدای مرا؟
بله.
ما قبلا نظر به تقاضای دوستای افغان، چون از سراسر افغانستان بودن، دوستای همکارای افغان ما گفتن اگه به لسان انگلیسی باشه بر ما آسان‌تر از به یک نگاه، به او خاطر ما به انگلیسی ما هم پرزنت میکنم و بعد از تمام سوالا را به لسان دری یا پشتو گپ میزنیم. My topic, there are many complications of COVID. So considering the very extensive talk about the treatment, I try to focus only on acute kidney injury as possible complication of COVID-19. And we will hopefully come back to the other complications later to discuss the other possible complications. What I will be going to talk about today is the pathophysiology of acute kidney injury, mainly related to the COVID, very specific to this population, and what can you do about the treatment, And I have some slides at the end for the centers who do have the possibility to dialyze, and what are the alternatives, how can you help your patients. At this, to start with, kidney involvement is very frequent in patients with COVID-19. We see in more than 40% of cases who present at the hospital, they already have proteinuria, which is a sign of a kidney damage. In addition, the patients who are admitted at intensive care, and 20 to 40% of them, you see the acute kidney injury, that they really have the injury. So it's 20 to 40% is actually a very high number of patients. And one of the points that I want to mention at the beginning already is that it is also considered a marker of the disease severity, and it has a negative prognostic factors for survival. If you have a patient with chronic kidney disease, and not with chronic, with acute kidney failure and infected with COVID-19, that's actually a sign of a multi-organ failure. That's how we see that. The prognosis is very poor. Unfortunately, in these patients, you have to at certain moment stop the treatment because you see that there's already a organ failure, multi-organ failure, which has shown itself, has manifested itself as a kidney injury. And what is very important for you as a physician responsible is to recognize the kidney injury. And the use of preventive and therapeutic measures are very important to limit the severity of acute kidney injury. I'll come back to that part later. But what is also one of the problems is that the kidney failure is usually very much missed, especially at the beginning. And so when patients come to the hospital, to the emergency room, as you do not have an earlier kidney function, not in every patient, you see that they already have an elevated creatinine. And that causes delay in the treatment. So the most important thing is to follow the kidney function on a regular basis and see if there is any deterioration of kidney function. And how to recognize that, I have a slide for you here that you can look at the GFR. At the left side, that's the GFR criteria, the glomerular filtration rate criteria. And then the very first row, they show the patients who are at risk of developing kidney failure. The second row is the patients who already have the injured kidneys. And the third one is the failure of the kidney. And you have the two criteria for that. One is the glomerular filtration rate. So you see a decrease of more than 25% and 8 to 24 hours. If it's injury, it's more than 50%, and in failure, it's more than 75% decrease in GFR. If somebody has already some deterioration of kidney function, but it remains stable, then it's less severe than acute kidney injury. But also urine output. Sometimes the GFR criteria is delaying because of the limited facilities and laboratories and not being able to take the blood samples on time. You can also look at urine output per hour. And if the urine output is less than half milliliter per hour per kilogram per body's kilogram of that specific patient per hour, and you see that it's low for 6 hours, it's already at risk. You need to take an action. And if it's more than, for less urine output in about 12 hours, then the patient has already injury. And for more 24 hours, then it's kidney failure. That's how we define that. And this pathophysiology, this is actually the part that makes this presentation also very specific for COVID patients. The causes of kidney failure is multifactorial. Cardiovascular comorbidities that most of the COVID patients already have. It is diabetes mellitus, hypertension, obesity. Those are the known comorbidities that the patients have, but also predisposing factors like sepsis, hypovolema, and nephrotoxins. I will come back to that in more details later, and also a cardiorenal syndrome. We call it sandwich kidneys, and I will present that in a minute as well. And there are some very beautiful data published recently in Lancet, and they had an autopsy of patients who had proven COVID-19, and that they could do a histology test of the kidney. Last week we had some cases in our own hospital as well. It was also presented. They found that the endothelium itself is affected in the lungs, but also in the kidneys, and that causes the leakage, capillary leakage, and causes the proteinuria. And they also have found the virus particles. The virus particles were reported to be present in the renal epithelial cells. And then that indicates that viremia is a possible cause of endothelial damage, and that causes also direct damage of kidney. I'm going to show you this image, and this is also like most of the previous slides, a little busy, but I will take you to every line, and I want you to follow the line from the left to the right. The very first one is the line which goes from the virus to the left, the very first one, and it shows you the endothelial damage, podocyte localizing, and proximal tubal localization, and they all cause also acute tubular necrosis, ATN. So the virus itself, it causes that's actually also because of the presence of angiotensin converting enzyme type 2 in the kidney, and that is how the virus enters the cell. So that's the involvement of that receptor as well, which causes also, we call it collapsing glomerular. And that gives if you follow the line at the end, and now you see it gives the direct acute kidney injury. That was the first one. The second one is hypovolemia. The line that you follow, patients have sepsis, they have patients have sepsis, they have low blood pressure, they have, because of the fever, they also lose a lot of water, they also have the tertial space, and that all causes hypertension, and hypovolemia causes also direct kidney injury. And the third line is the very most also concern, point of concern, and that they call it cytokine storms. And that is the huge amount of inflammation, the cytokine activation, and the abbreviation that you see as DAMPS, that's actually the damage at the molecular level. So the cytokine storm will damage the kidney on the cellular and molecular level. And it also causes the endothelial dysfunction. So this is one of the third way that the virus directly, or the second way that the virus directly causes the acute kidney injury. In addition to that, pneumonia itself and acute respiratory distress syndrome, you see that via the lungs, the acute respiratory distress syndrome and mechanical ventilation, they cause some high pressure in the lungs, which gives a backward failure, which causes the higher pressure in the right ventricles and the right atrium, and that causes for higher pressure in the vena cava, and that gives the higher venous pressure, so the kidneys cannot drain properly in the venous system. That's another effect that causes the acute kidney injury and kidney failure. If we go down to the next arrow, you see that hypercoagulability, and that has on its own many different factors, which shows the myocardial dysfunction. And myocardial dysfunction was the cardiorenal syndrome that I told you in the previous slide. And that when you have this cardiac dysfunction, you have the forward failure because the heart cannot pump properly and the kidneys are not perfused properly. But they also, because of this dysfunction, you also see the backward failure. That's what I just explained with the lungs, that the venous pressure also increases. And that is the condition called the sandwich kidneys, that they have forward failure, they are not perfused, but on the other side, what they do receive, they cannot pump it properly. And as a last factor, you can see that endothelial damage we have already mentioned for many different ways, and rhabdomyolysis, which is also a destruction of muscle cells directly by a virus, and they cause a very high cell damage and high CK, which also causes the kidney injury. So there are many different factors, many pathways, and this is actually the image that we see recently in most of the publications and the pathophysiology behind the acute kidney injury. How can you manage this? This is the biggest challenge that you face, and this is actually now going back to what we usually see in the kidney failure. I recommend you to, I don't know which guidelines you usually use, but improving global outcome, KDIGO is the very handy and very clear, very structured guidelines. It gives the supportive care, a special subject on acute kidney injury. And the most important is that as early as possible, avoidance of neurotoxins. I show you, the first one is RAS blockers and angiotensin receptor blockers and ACE inhibitors. This is the moment that you can stop it. At the beginning, we have mentioned that a couple of times, also in previous lectures, as prevention to COVID, you do not have to stop this medication. But if a patient has kidney injury, stop RAS blockers. We have had this image, all of us, sometimes in physiology before, but just a reminder that this, you see the glomerulus at the right side, which is the efferent, which the blood goes out of the kidney. That part has a vasoconstrictor. That part is constricted by angiotensin II. When you give this RAS blockers, they stop this vasoconstriction. So what happens that the efferent arteriole, which you see on the right side, it will be dilated. That causes higher pressure, and it causes lower pressure and glomerulus, and the kidneys cannot filter properly because of that low pressure. But once you stop the RAS blockers, this constricting effect of angiotensin II will come back, and there's a higher pressure and glomerular, and they can glomerulus, and they can filter better. So this is the moment that you can stop the RAS blockers, and but you can start it sometime later. Antibiotics, adjustment of dosage, avoiding gentamicin, vancomycin. Try to, even if you have to give it, because there are no other possibilities, no other limited facilities, make sure that you get the least needed dosage. So adjust the dosage as much as possible. Screen the home medication. Anti-diabetics, metformin, which is given very often in all diabetics patients. They give severe acidosis if the kidney function has failed. Other home medication that they have had, try to make sure you check adjust the dosage that they use. Anti-epileptic medication, painkillers that they use just because of some arthrosis, they have years of ibuprofen, diclofenac. Screen the home medication. That's very important for patients with kidney failure. Antihypertensives. They usually, even with here in Holland, if you look in the drawers of the patients in their room, they always have some medications with them they have taken from home. That I'm using this for years. My husband has given this to me. My brother has given this to me. Make sure they do not have those antihypertensive medication, diuretics, or especially if they're hypovolemic. And another important issue is the contrast. As explained earlier, you always, not really always, but sometimes you do have a very strict indication for a CT, for example, for pulmonary embolism, or a CEG because of a cardiac problem, then you cannot avoid it. Avoid it as much as possible. But if you have to give it, make sure you prepare the patient. There's a whole prevention program, prevention protocol. If you need it, we can discuss that later in the discussion moment. Just let me know how you can, if you have any questions, how to prepare a patient with kidney failure for the contrast. There's a whole protocol. I'll share it with you. These are the important issues. Then fluid balance. Adjust the fluid balance. So you can do that during physical examination, central venous pressure, peripheral edema. Lungs are a bit difficult to evaluate properly in COVID patients, but that's still important. And X-ray, you still see the volume overload on X-ray, despite the abnormalities of COVID. Make sure you store normal volume status to avoid volume overload. This is one of the points, because the volume overload, by bringing the volume status back to normal, you will reduce the risk of pulmonary edema. And that's beneficial on its own patients with COVID. But as I just explained, you will reduce the right ventricular pressure, overload congestion, and you can prevent further deterioration of kidney function. So that's very important to make sure that the patient is not overloaded. We have, I think I'll come back to that point later as well, but we have the facilities to dialyze patients if they are really volume overloaded. And we try to keep our COVID patients as dry as possible because of their lungs. But because that facility is not always available, not in every center, make sure you start on time with prevention. For example, with fluid restriction, make sure the patients are in a euvolumic status. But also volume depletion is also very important. But as I showed you in previous slide, the hypovolema itself is a very important cause of the kidney failure. So volume depletion at admission might be common in many patients because, as I told you, they come with high fever, sweating, but also we have seen many patients with vomiting, diarrhea. So hypovolema should not be missed, and that can have very direct effect on initiating kidney failure. And the complications, I discussed already that hemodynamics is very important to focus on volume overload. And how do you do that? We advise diuretics. If you know the patient has peripheral edema is hypertensive, then you can start diuretics. The intravenous administration is much better because, at least in this population, when there is severe edema, and normally they say there's not a big difference, but those who are, but the generalized edema, there's a theory that also the intestine will have some edema, so the admission and absorption of the diuretics from intestine is less if patient has a lot of edema. And loop diuretics are the first choice, but if there are combinations, if there are problems with electrolytes, for example, hypernatremia, hypokalemia, then you choose for a combination of diuretics. And you can add a thiazide diuretics. And that centers that they do have hemodialysis, unfortunately, the volume overload is one of the major indications of dialysis, and you have to start dialysis or CVVH. So as I mentioned in the previous one, try to evaluate the volume status every day and make sure you're on time with starting the diuretics or fluid restrictions. Metabolic acidosis is one of the major issues. If you can give the patient infusion because of hypovolema, make sure that you alternate the infusion with NaCl and sodium bicarbonate. I don't know if you have it, but you can have it in different percentages of 1.4, 4.2, and 8.4. But that can be used directly but also oral supplements are very good, very effective. We have very good experience. And it's also the question, if it's only the kidney failure, you should always check the other sources of metabolic acidosis. If there's a lactate formation, is there ischemia, is this what I earlier mentioned, metformin is used, which causes acidosis, or it's pure, most of the time, normal onion gap acidosis, which is because of the kidney failure. In that case, you can just give a sodium bicarbonate. The other most important complication is hyperkalemia, high potassium. The first question is, has this patient ECG abnormalities with hyperkalemia? Then it's a need for an urgent treatment. Otherwise, you can adjust the diet and follow another route. And what we always remember is that the potassium is sleeping under the T wave. So when you have the spike T waves by hyperkalemia, then it's an ECG abnormalities. You have to take an action right away, otherwise it might cause some severe rhythm problems. We give calcium intravenously, but if you admit that, you should make sure you have the rhythm observation, cardiac rhythm observation. Otherwise, glucose is insulin. We give 6 units of insulin and 50 cc, 50% glucose. You don't have to remember it right now, but I thought I write it down in this slide. If you need it later, you can check it up. And what you can expect from glucose insulin is that potassium decreases to 1 millimole per liter in 1 hour. And it's very effective. In 10 to 20 minutes, you see the effect, but the problem is that in 6 hours, the effect is gone. So in 4 to 6 hours, you need to again check your potassium, because that causes the potassium to go into the cell. In 6 hours, they slowly come back to the circulation, 4 to 6 hours. So you need to check and repeat the treatment if you don't have the possibilities to dialyze or to have other what you can also do is, the last point in this slide is that sodium, that we give resonium, sodium sulfonate. That's also effective, but that does not work right away. You can start that and to buy some time, and this the time you need for 24 hours, you can use the glucose insulin infusions. And where possible, adjust the diet. Bananas, tomatoes, they all are bombs of potassium that, if possible, just avoid that. Hyperphosphatemia does not have many solutions than phosphate binders, and that can be taken during the meal. Most of the time, people just take it early in the morning or just after the meal, like other medication, or whenever they think of it. But this should be taken just really during the meal, otherwise will not be very effective. Hypokalemia, hypercalcemia, all of them can be corrected where possible by oral medication, sometimes also intravenously. Hemodialysis, colleagues who have hemodialysis in their center, they can apply that to their COVID-19 patients, but the biggest challenge is if the patient is hemodynamically unstable. Patients who are not stable, you cannot connect them to hemodialysis machine. They all have a resuscitation within a minute. So hemodynamically, stability is the main limitation, the biggest challenge that we also face here. And for those who have the intensive care with CVVH, with continuous venous hemodialysis, you can apply that. That's the most wonderful treatment available. However, that's not available there everywhere. So the alternative for that is to have this slow, low efficiency dialysis slit. There can also be daily dialysis with double D. Slow, low efficiency dialysis is a option that it's actually the regular hemodialysis machine, so you don't need any extra machine, any extra cassettes for it. You need to have a vascular access. Most of the patients with acute kidney injury do not have an AV fistula, the arteriovenous fistula, what we the hemodialysis patients have, but you can give them a dialysis catheter in the one of the jugularis veins, so you can give central venous catheter, and you can offer them then slow, low efficiency dialysis. And that I go to the next slide. The best thing is that you can adjust the temperature, so use the lower temperature, and you can dialysis for 8 hours, sometimes shorter, 6 to 8 hours. And this, I put some important points of the protocol in this slide, but I had the honor to write the regional protocol for this dialysis. And we regularly do not need that, but there was a fear that the intensive cares might get overloaded and we don't have enough CVVH machines, so we should have an alternative. If you have the dialysis center, if you have the opportunity and you need the protocol, just let me know via the team of COVID-19 in the Netherlands. I will offer you the whole protocol, how to work with it. But the whole idea behind it is low temperature, dialysate flow is very low, and blood flow is also relatively low. But you do, and definitely you need anticoagulation for this system. And what I told you, there's a whole protocol for it. That was about the acute kidney injury. I just want to use this last slide to emphasize one point, that do not forget your chronic kidney diseases in these crisis periods. Those patients, make sure that they have sustainable care. And as I told you, ACE inhibitors, ARBs should be continued in this population. Usually what happens in these crises, and the whole attention goes to the stage 4, 5, so the pre-dialysis patients. But do not forget that stage 3, they are more fragile population because they don't get their medication in this crisis period. They don't get their antidiabetics. They do not receive their antihypertensives. And just by the time you're done with the crisis, you get a huge wave of these patients ending up in dialysis and kidney failure. So with all the hectic of the acute kidney injury and crisis, do not forget this chronic population. I have some more ideas with references, but I think it's good to go to discussion and focus on your questions and see what, how, if needed, then I'll give some more explanations.
تشکر بسیار زیاد دکتر صاحب محترم، واقعا کردو لکچر معلومات خیلی مهم و خلاص راجع به کووید بود که برای ما به صفت متخصص جهاز هاضمه هم خیلی چیزایی را یاد گرفتم در طول همین 4 هفته. 2 سوال است. سوال اول از همکار ما سید مسیح جان هاشمی است. بفرمایید، خودتان میتونین سوالتان عرض کنین دکتر سید هاشمی.
تشکر از شما و تشکر از دکتر صبایی که لکچر دادن. واقعا آموزنده بود، چیزای زیادی بود که مختیم از لکچرشون. سوال ما از دکتر صاحب نادری بود که در قسمت منیجمنت یا تداوی مریضا از رمدیسیویر یاد نشد، در حالی که رمدیسیویر تنها یگانه دوایی است که از طرف خود FDA آفیشیلی اپروف شده به خاطر امرجنسی یوز. سوال ما است که در هلند یا در نیدرلندز از این دوا شما استفاده میکنیم بر منیجمنت مریضا یا که هنوز شما از این استفاده نمیکنید، در رژیم تداویتان شامل نیست؟
بسیار سوال خوب، تشکر بسیار زیاد. ما منتظر از این سوال بودم به خاطر از اینکه این دوا است که اپروف شده ولی تنها به اینوستیگیشنال تریتمنت. این تداوی، این دوا هنوز اپروف نشده برای ریگولر تداوی کووید 19. دلیلش است که جیلیت کمپانی که را تولید کرده بود در شروع بسیار شرایط مشکل را ایجاد کرده بود که این دوا را تقسیم کنه. در شرایط اولیش طوری بود که هر شفاخانه اجازه داره که این دوا را شامل امی ترایل شوه دوا روان میشد برای شفاخانه. کریتریاش بود که باید مریض یا پرگننت باشه، عامل داشته باشه، کووید داشته باشه و دیگه ای که در شفاخانه بستر باشه، شرایط کاتگوری سیویر یا کریتیکال داشته باشه که بتونه این دوا را بگیره. در حال حاضر در اروپا، در امریکا و بعضی کشورهای دیگه این دوا را استفاده میکنن تنها در جریان investigational trial، investigational treatment تا وقتی که دیتای نو پیدا شد.
تشکر دکتر صاحب.
تشکر. سوال دیگه از همکار ما محترمه دکتر صاحب استوره افضلی است. بفرمایید سوالتان میتونین خودتان عرض کنین دکتر صاحب افضلی.
السلام علیکم. امیدوارم اگه دکتر صاحب صحت کامل داشته باشن و تشکر از اساتید محترم. میخواستم پرسان کنم در افغانستان یک ایده است که کسانی که مثلا به خود کووید هنوز مصاب نشدن بعضشان به شکل وقایعی از خود هیدروکسی کلورکین استفاده میکنن. در ارتباط با آیا به شکل به خاطر سیویریتی از یک دو مقابل بعداً پیش شوند از این میگه جلوگیری میکنن؟ آیا این ایده درست است یا خیر؟ و سوال دوم این است در صورت که یک شخص مصاب شده باشه دوباره جور شده باشه و همین مسئله استفنسی که در قسمت راس و یا قسمت فک یا داشته باشه به خاطر از اون میتونیم چی راهکارهایی را در پیش بگیریم؟ تشکر.
سوال بسیار خوب. یک سوالش من جواب میدم و یک سوالش مربوط دکتر لیما میشه. بخش اولش که پروفیلاکسیس تداوی، پریپ یا پری اکسپوژر پروفیلاکسیس در کووید 19 هیچ جایگاهی نداره. حتی کسایی که مریض میشن مایلد سیمتوم دارن، سیمتوم بسیار خفیف، اونا رو ما تداوی نمیکنیم. تقریبا 80% تا 82% مریضایی که کووید 19 میگیرن اونا اعراض و علائم بسیار خفیف دارن. اونا هیچ گونه ضرورت بر تداوی ندارن. برای کسایی که هنوز مریض زیر نگرفتن، گرفتن یک دوایی که ساید افکت عوارض جانبی زیاد داره و نتیجه از اون تا حال معلوم نیست، ما هیچ ادویس نمیدیم و تداوی نمیکنیم اون مریضا. و بخش دومش راجع به ایس بلاک بود که دکتر سلیکی گفت.
بسیار معذرت میخوام، میشه سوال تکرار کنین؟
گفتم بعضی که وقتی که با خود کووید مصاب شدن دوباره صحتیاب شدن، مسئله استفنس در قسمت جو و قسمت راس دارن و یا قسمت نک، به اینو چی توصیه میتونیم بکنیم؟
اوکی. استفنس.
ساری. ببخشید من درست صحیح نشد. من فکر کردم که به ارتباط راست بلاک بود. گفتین که اگر خوب متوجه شده باشم سوال شما را، کسایی که مریضی را سپری میکنن بعد از اینکه جور میشن یک سلسله شکایتشان هنوز میمانه. درست شنیدین سوال دانه؟
بله بله.
ما یک حالت داریم به نام پست وایرال انفکشن. در سایر امراض انتونی مخصوصا امراض ویروسی مثلا دنگی فیور، چیکنگونیا، مثلا اپشتین بار ویروس، سیتومگالو ویروس، ما پست وایرال سندروم میبینیم. یک تعداد مریضا میمانن امرای بعض اعراض و علائم. مثلا در چیکنگونیا ما خود مریضایی داشتیم که تا 3 سال بعد از اینکه چیکنگونیا را گرفته بودن هنوز هم آرترالیشی داشتن، مفاصلشان بسیار شدید درد میکرد، استفنس داشتن و او آیسته آیسته از بین میره. ما سیمتوماتیک رو تداوی میکنیم. در قسمت کووید 19 چون یک مریضی کاملا جدید است، ما قدر معلومات کافی هنوز نداریم که بتانیم بگوییم که چگونه کانسیکوئنسز برای مریضا باقی میمونه. نظر به دیتایی که ما حال داریم ما میبینیم که یک تعداد مریضا گلنبری سندروم پیدا کردن بعد از کووید 19 و حتی در جریان کووید 19. خب این مریضا طبعا مشکلاتشان تا یک زمان باقی میمونه. یک مریضا میوسیتس پیدا میکنن و مخصوصا در جریان مریضی CPK یا کراتین کینازشان به اندازه بالا میره و یا آهسته وقت کار داره تا که پس بیاید. ما فکر میکنم که یک سلسله اعراض و علائم در مریضا باقی میمونه، اما ما نمیفهمیم که تا چی وقت، ما نمیفهمیم باشه و ما ایرم نمیفهمیم که تا چی وقتی را دوام میکنه که کووید 19 داشتن او را بستر کردیم. بعد از اینکه اونا خانه رفتن ما هفته یک بار راشن تلفنی گپ میزنیم و اونا را ما حداقل بر 6 ماه میخوایم که تعقیب کنیم. در اول در روزهای اول حتی هر روز یک روز بعد تلفنی گپ میزدیم، بعدا هفته یک بار شد و از این بعد ما یک بار هم راشن تماس میگیریم که ما زیادتر معلومات بگیریم که چگونه اعراض و علائم بین از این مریضا باقی میمونه و long term complications are not clear yet.
بسیار تشکر استاد.
تشکر بسیار زیاد. فقط یک سوال ما از همکارای افغانستان به خصوص خود خانم افضلی صاحب، یعنی معلومات شما دارین بعد از اینکه قسمی که اشاره کردن دکتر صاحب نادری، بعد از اینکه در افغانستان مریضا تداوی میشن بعد مصاب کووید 19 شدن، آیا کدام تعقیب از مریضا وجود داره، کدام پروگرامی وجود داره، یا یک خانه که رفتن یا با دیات خود یا هر جایی که رفتن دیگه کدام تعقیب وجود نداره از مریضا؟
ببخشید دکتر صاحب، از ما در خارج بودن یعنی در اروپا بودن تا بالا که میکنن اونا هم تعقیب تلفنی میکنن، اما از افغانستان درست معلومات ندارم. شاید هم کارایی باشن که در جریان اونا تعقیب شن، ولی فکر نکنم تعقیب، به خاطر مردم هستن که شماره تلفن دارن که از اوقات قید میکنن و یا گپ های دکتر دوباره تعقیب نمیکنن. معلومات درست ندارم.
نه فالو اپ نیست دکتر صاحب. فالو اپ در افغانستان مریض یک فرزند از شفاخانه دیسچارج میشه، دوباره سیستم فالو اپ نیست که فالو اپ شه. خب
تشکر. بازم کدام سوال دیگه هست؟ دوستا هستن سوال داشته باشن در غیر از او پروگرام همیجا خاتمه میافته. اگر سوالی وجود نداشته باشه، واقعا هر دو لکچر خیلی جامع بود و لکچرها ثبت هم میشن. تعداد دوستا در اوقات لکچر تا به 35 و 38 و 40 نفر هم رسید. نظر به پروگرام نت میشه که امکان داشته باشه که دوباره نتونسته باشن وصل شده باشن، اما پروگرام ها را میتونن دوباره تعقیب بکنن. تشکر از همکار عزیز ما که هر دو با وصف مشکلات و مصروفیت های زندگی و کاری که دارن آماده به این شدن که در پروگرام ما وصل شوند و داشته های خود راجع به کووید امرای هموطنان ما در سراسر جهان به خصوص در افغانستان شریک بسازند. اگر دیگه سوالی نباشه پروگرام همیجا خاتمه میدیم و به دوستا در افغانستان افطار خوش و اشتیای خوب میخواییم و انشالله با هفته بعدی البته که عید است، ما یک وقفه به خاطر عید داریم و بعد از یک لکچر آخری به ارتباط کووید است و بعد از کووید نظر به تقاضای دوستا پروگرام‌های جدید روی کار میشه که در قدم اول در بخش رادیولوژی است که با شما شریک خواهد ساختیم که متخصصین رادیولوژی ما از آلهند آمادگی خود با همکاری از متخصصان در افغانستان با هم اعلان کردن که و پروگرام‌های بعدی را شما شاید تعقیب کردین. بخیر بفرمایید مرسل دکتر صاحب. عمر شما سوال داشتین؟
سلام علیکم به تمام استادای محترم و دکتر صاحبا. سوال من این بود که چطور بفهمیم که در یک جامعه مرض کرونا به پیکش رسیده؟ مثلا بعضی ها میگن که در بعضی ممالک به پیکش رسیده و بعد از او رو به کاهش نهاده. پس چطور، یعنی امیر چطور میسنجن؟
اگه اجازه باشه من میخوام جواب بدم. اصلا خود کووید 19 در هر کشور به شکل دیگه خود نشان میده و یا یک بستگی به این داره که او کشور چگونه تدابیر را اتخاذ کرده تا که کووید لیمیتد بسازه. ایده از این که کووید به کلی ختم میشه وجود داره. تمام کوشش کشورها تا به حال این بوده که تعداد مریضایی که به اینتنسیو کیر میرسن او تعداد زیادتر از کپاسیتی خود از اون مملکت بالاتر نره. ما میفهمیم که تقریبا 14 تا 15% مریضایی که کووید میگیرن اونا مودریت تو سیویر و تقریبا 5% تا 6% مریضا کریتیکال استیج میگیرن که اون تعداد مریضا در اینتنسیو کیر میرسن. تمام تدابیر که کشورهای اروپایی و کشورهای امریکایی و بعض کشورهای دیگه در آسیا گرفته بود این بود که زور کپاسیتی یا کیر کپاسیتی یا شرایط و تعداد مریضایی که به اینتنسیو کیر میرسن زیادتر نشه از ظرفیتی که خود از اون کشورها داره. اگر کشورها هیچ گونه تدابیر نگیرن پیک بسیار بالا میره، پیک کسایی که به اینتنسیو کیر میرسن بسیار بالا میره، تعداد کسایی که مریض میشن زیاد بالا میره و اگر کپاسیتی یا ظرفیت شفاخانه ها و ظرفیت صحت عامه کمتر باشه از تعداد مریضا کرده او کشور دچار پرابلم میشه. اگر کشورهای مثل بعضی کشورها که وقت انجام دادن بعضی تدابیر را گرفتن مثل لاکداون، مثل سوشال دیستنسینگ، مثل استفاده ماسک ابلیگاتوری، مثل اسکرینینگ، اکتیو اسکرینینگ زیاد کسا و تریسینگ مریضان. مثلا یک مریضی که مثبت شده او را دیدن کمرکی ده تماس بوده و دیگه از خانواده هم یا کوشنیر روان کردن برشن که بس سوالات جواب بدن یا تست کردن. به این صورت اونا تانستن که امی کرف کمک به حساب فلات بسازن به این وضعی که پیک بالا بره و دفتن این آیستا آیستا مانن که بالا بره و همزمان ظرفیت صحی در شفاخانه ها انفراستراکچر خود از بالا برد. بسیار مشکل است که بگوییم که کدام کشور پیک خود گرفت. مثلا ایتالیا را ما میتونیم بگوییم که پیک خود گرفت در بعض نقاط ایتالیا. مثلا لومباردی سایی بود که زیادترین تلفات اونجا آمد چون آمادگی نداشت، بنابراین در اونجا پیک خود گرفت، در حالی که دیگه مناطق ایتالیا آمادگی خود گرفته ولی آل کوشش میکنن که ادامه بدن تا وقتی که یک واکسن پیدا شه و همگی واکسن کنن کسایی که هنوز مصاب نشده. بنابراین بسیار مشکل است که بگوییم کدام کشور پیک خود گرفته یا نه. مثلا چین تقریبا 1.5 میلیارد نفر در لاکداون ماند برای 2 هفته یا 3 هفته. خب میتونیم بگوییم که چین در اون وقت پیک خود گرفت ولی ما میفهمیم که چین تا وقت واکسن نیاید احتمال زیاد وجود داره که پس یک تعداد زیادشان مصاب شن و اگر مصاب میشن چون چین آمادگی کافی داره انفراستراکچر خود بسیار خوب کرده حال ترس زیر نداره که مثلا تعداد زیاد مریضا بیاین در اینتنسیو کیر و دیگه ای که حال زیاد معلومات هم به دست آوردن راجع به این مرض. مشکل است که بگوییم که پیک در کدام کشور چی وقت به اوج خود میرسه و چیزی که ما میبینیم در اروپا مثلا در هلند تعداد کسایی که مصاب میشن روزمره کم است از سابق کردن. دلیلش است که تدابیر لازم گرفته شده و ای که در زمستانی پس میآید بسیار مشکل است که جواب بدم.
تشکر.
بازم تشکر بسیار زیاد. روز همکاران هلند و شب همه وطندارای ما در افغانستان بخیر. تا پروگرام بعدی شما را به خدا میسپاریم. تا دیدار بخیر. خدا حافظ شما.
تشکر. خدا حافظ.